Good afternoon, everyone. Welcome to the May episode of the Australasian Pleural Seminar. So today we are very fortunate to have Dr. Vin George, who is a chest physician who leads the pleural service in John Hunter Hospital in Newcastle, Australia. And he's also affiliated with the Hunter Medical Research Institute and University of Newcastle in Australia. He's going to talk today about recurrent transudative pleural effusions. So transudative pleural effusion is actually more common, but far less studied than exudative pleural effusions. So this is a very good opportunity to discuss some of the commonly encountered clinical issues. Just to remind everybody, we will aim for about 15 minutes of talk, but we will need everybody to participate and put their questions on chat, and we'll be monitoring on chat. So if you want to start during the talks to put in your questions, then you'll be top of the queue. And the seminar is recorded, so you'll find it in YouTube. If you go to YouTube and tap in the Australasian Pleural Seminar, you should be able to see all the previous videos as well. So without further ado, so Vin, we'll ask you to share the screen, and
Sounds good. Thank you, Gary. So thank you, Gary, and afternoon all. So this is really an area that doesn't have a lot of evidence, and so a large part of today is going to be about opinion. And as part of today's talk, I'm hoping that we can share some ideas, and a large part of that is going to be a series of polls. So if you don't mind just scanning the QR code here, there will be questions during the course of this presentation, and it will allow us to kind of spring ideas off each other. So if you don't get that code, there will be other opportunities during the course of the afternoon. So this is going to be a relatively rapid look at refractory transudates. We'll look at an illustrative case. This is going to be something that is typical, not necessarily complex. We'll look at diagnostic approaches to transudates. Look at just how benign are these effusions. I mean, Gary hinted at that, but often these people have awful outcomes and marked morbidity, and then look at our therapeutic options or lack thereof. So this is Mr. SB. He's a 47-year-old gentleman who presented to our hospital with a 2-day history of dyspnea, cough, fevers, and left-sided chest pain. He also had a history of progressive peripheral edema and had this new diagnosis of liver disease that had been made in primary care. And this all occurred in the context of polysubstance abuse. So he presented in extremis. He was found to have features of decompensated liver disease and also had crepitations throughout the left lung field in keeping with a lower respiratory tract infection. And so his chest x-ray kind of confirmed our clinical findings, and so he had widespread airspace opacity on the left with what appeared to be an effusion. And this is a CT slice from the level of the lower trachea, and it is representative. So he had a moderate to large effusion on the right side and airspace opacity that was thought to be in keeping with pneumonia. So to start off the questions, I just find, so this was a guy who was in extremis. He would end up getting tubed the day of presentation and ventilated in ICU. And the question is, what is the most appropriate management strategy for this effusion? So for many of you on this call, this will seem very simple, but I am mindful of the fact that we've got trainees of all levels joining us today as well. So I'll just give you about 30 seconds to think about what you would do for someone in this setting. So he's come in extremis, he's got respiratory failure, he's been tubed, and he has a moderate to large right-side diffusion and what looks to be a pneumonia on the left. Okay. And so we can see here that there's a real variety of opinion. So out of the just under 20 respondents, you can see that almost half will insert a 12 French or larger chest drain. About a third will perform a large volume aspiration, and about a quarter will offer diuretic therapy. So that's very interesting, and we can talk about the pros and cons of those approaches. Taking a step back, though, I think it's important to look at the terms transudate and exudate. So this is a slide from Professor Najib Rahman in Oxford, and so these are really terms used to define the mechanism of fluid formation. So trans meaning across the pleura, across the visceral pleura, and so you've got normal underlying pleura, and exudates being of or from the pleura, and so the pleura is diseased. And all of you would be familiar with Light's criteria. This is one of the most widely cited criteria in all medicine, but it does have some limitations. And key amongst those is that it misclassifies about 25 to 30% of transudates as exudates. And of course, we know that about 5% of patients with, or 5% of malignant pleural effusions will be transudative as well. So it does have its limitations. And often in left ventricular failure, clinical gestalt will outperform Light's. So what did Mr. SB's pleural fluid look like? Well, it was very interesting because the first intensivist that looked after him didn't want to instrument that right effusion. After handing over to a colleague in 2 days, that person did, and they inserted a chest drain, and it revealed an effusion that was consistent with a transudate with a high glucose and pH. And so they put the drain in, and they experienced 4 litres of output in the first 48 hours. And so the question then is, what would you do next? And once again, same thing again, I'll see what the responses are, and we'll go from there. So I'll give you 30 seconds or so to respond to this one. Okay, in the interest of time, I'll keep moving. We have about a half of people want to continue free drainage, 22% want to offer an IPC, and a third want to remove the drain. So the respiratory advice for this patient at the time was to remove the drain, and this is where he ended up, although he was now on the ward. And so the question I'm going to ask is there any point offering this person pleural intervention? And it's often a philosophical question that I've certainly seen asked on the wards at the John Hunter. And I would argue that there certainly is. And I suppose the question is how best we offer that intervention. So we know that the main reason we intervene in this group of patients, like all patients, is to alleviate breathlessness. So this was a very elegant study from Gary Lee's group called the PLEASE study. And they looked at 145 patients who underwent pleural drainage, large volume drainage with a median drainage of 1.68 litres. And it's worthwhile saying that 15% of this cohort had cardiac failure, and about a third had so-called benign pleural effusions. And so the reason we intervene is to alleviate breathlessness. We don't have high quality data to suggest that our interventions improve hypoxia, and indeed the data that we do have, admittedly from ambulatory population, suggests that it doesn't. The other really interesting bit of work that I won't have time to cover today, once again by the same group, is looking at the effects of a pleural effusion on the contralateral diaphragm. So not only do these people experience significant relief of breathlessness, but in many cases, there's reason to suspect that they will be even more responsive to our interventions, but not in the ways that we might want. So anyway, Mr. SB had another thoracentesis on the ward. The hepatology team reintroduced his diuretics. This was complicated by ongoing hyponatremia. He commenced hepatitis C treatment. He was considered not a transplant candidate or a TIPS candidate, but he deteriorated and returned to ICU again, had another drain inserted, 3.8 litres drained, and passed away after being palliated. And so this is a person who's been cared for at a tertiary Australian hospital. He's had 3 procedures, lots of fluid drained, and has had ongoing symptoms and a very poor outcome. And the unfortunate reality is that this is all too typical. So Gary's already touched on the fact that the incidence of so-called benign pleural disease outweighs that of malignant effusions. We know that this is associated with significant resource allocation, and often these patients fall between the cracks. There are multiple specialties looking after these people, particularly the ones that have transudative effusions. Now, there are lots of causes of transudates, there's lots of causes of benign effusions, but in the interest of time, I'm only going to focus on the three main ones today. So that's heart failure, which accounts for about 80% of transudative effusions. And we know that when we do CT studies on these patients, the overwhelming majority will have an effusion on CT. And if you look at autopsy studies, it's about 70%. Important to note that it's unilateral in a third of patients. Liver failure or hepatic hydrothorax is frequently right-sided, but can occur on the left side, of course, and be bilateral. Patients often don't have clinical or radiologically detected ascites, and about 5 to 10% of patients develop a pleural effusion. 5 to 10% of patients with cirrhosis develop a pleural effusion. And there's lots of postulated mechanisms of which diaphragmatic defects appear the most likely. And the final large group, of course, is end-stage renal disease. Once again, we see this frequently in dialysis populations where effusions are typically bilateral once again, and hypovolemia is the most common cause. But it's also important to remember that these patients have a higher rate of parapneumonic effusions and empyema, and of course uremic pleuritis and translocation of dialysis fluid. So how does this group go? Well, poorly is the answer. So often what we're seeing here is disease that is a marker of severe end organ failure. And so if you look at the one-year mortalities here, they are very high. And often when you look at outcomes in this patient population, they are markedly worse than our patients with malignant pleural effusion. Now, typically, most guidelines would say that you treat the underlying cause. There is some hope, at least anecdotally, that newer agents such as the SGLT2 inhibitors in cardiac disease are starting to reduce those rates of left ventricular failure leading to effusion. Transplantation, of course, is the definitive treatment and the gold standard. And in those patients with hepatic hydrothorax, TIPS seems to offer benefit as well, as does dialysis in those with renal failure. Of course, we are often asked to offer pleural intervention, and it's always a challenge here because we know that this is a group that do very poorly. They have debilitating symptoms, but often what we are faced with is the inadequacy of our own intervention. And that's probably the thing that makes it most challenging. We have used therapeutic thoracentesis, IPCs, pleurodesis, and more aggressive surgical measures. They're all seen in the literature and have all been used. Thoracentesis has only seen a fairly small number of patients randomized, but is still considered the standard of care, certainly in most guidelines. And very few patients have really been studied in a one-to-one sort of paradigm. The largest study looking at therapeutic thoracentesis looked at pigtail drainage in hepatic hydrothorax using propensity matching, and unsurprisingly, there was a higher 30-day mortality in those undergoing pigtail drainage versus those who had therapeutic thoracentesis. But it's, of course, without controlling or randomizing, the issue that you have is that clinicians could easily have offered those pigtails to more severe patients. IPCs have a wealth of data in the malignant pleural effusion setting. This is what an IPC looks like. So it's simply a chest drain that is tunneled through the skin with a safety valve on the end that allows for community drainage. And the first reported use for this for heart failure was about 15 years ago. We've had a series of single centre studies thereafter, which have really suffered from selection bias and a lack of external validity. But there have been reports of good outcomes from single centre studies. The REDUCE study, which was led out of Bristol by Steve Walker, really was the first major RCT to look at IPCs in this area and also look at therapeutic thoracentesis. So this was centres in the UK, 13 centres, patients with symptomatic effusion secondary to cardiac, hepatic or renal failure, and randomised 1-to-1 to IPC insertion or standard care. And standard care was defined as required therapeutic thoracentesis. Patients had optimal medical therapy prior to the trial, so their cardiologist, hepatologist or renal physician was asked to sign off on them prior to enrolment, and they needed to have a prognosis of greater than 3 months. And the primary outcome was dyspnea over 12 weeks from randomisation. So this is their consort diagram. You can see that they screened a very large number of patients. There were a fair number that were excluded for a number of reasons, and 68 were randomised. And you can see here that there was really no difference at all in dyspnea. So this is change in baseline daily mean visual analog score. And you can see on the y-axis there, that's the mean change in VAS, and day since randomisation on the x-axis. So the two curves quite clearly overlap. So there was not only no difference in breathlessness, but there was no difference in any patient-reported outcome measure. And the therapeutic thoracentesis group in this trial required, on average, 1.3 to 1.4 additional drainages during the study period. But really interestingly, the IPC group required an enormous amount of drainage. So they had an average of 17 litres drained compared to the 3 litres drained in the therapeutic thoracentesis group. And there was a large number of adverse events in the IPC arm. So the question then is, what do we take from this? This is probably the major recent trial in the area. This is a group that had very poor outcomes. Their quality of life scores were lower than studies of patients with pleural malignancy, which comes back to the point we were making earlier. And very interestingly, increased drainage volumes did not translate to lower symptoms or patient-related outcomes. So despite draining almost 5 times more, we did not see a difference in breathlessness. And the question, of course, is why? And I suspect that it has much to do with the multifactorial nature of breathlessness in this patient population. It is more than just fluid. And it's also worth noting that patients with therapeutic thoracentesis here had fewer complications, but the IPC group required fewer procedures. So pleurodesis, so once again, limited data, but what we do have suggests relatively high complication rates and mortality. We have, once again, small studies with propensity matched comparisons, and once again, no direct signal favouring pleurodesis. So, but all of this, I have no doubt, will be discussed during the discussion. So in summary, transudative effusions are common. As Gary mentioned, they are more common than much of what we deal with. They are associated with debilitating symptoms and a poor prognosis. And the thing that I didn't touch on today, but about 30% of patients with a pleural effusion will have more than one cause. So if you've got someone with atypical features in particular, then I think it's well worth sampling them and, if need be, proceeding onto a biopsy. And sequential large volume thoracentesis is considered standard in refractory cases, but I'm sure there'll be much debate on that. So I might leave it there and look to take some questions.
Excellent. Vin, thank you very much. And I should mention that Vin is also on the panel for the upcoming European Respiratory Society statement on benign pleural effusion. So there will be some consensus or guidelines, but as you have been saying, there's limited evidence, so guideline is only as good as the evidence that we base on. So if anyone has got any questions, please type it into chat, and then we can discuss. But I'll kick off. One of the problems we always have with indwelling pleural catheter for benign effusion is that, unlike for malignant pleural effusion, these patients live potentially a much longer time, even though I know you noted that 1 year mortality is poor. But the consumables, the risk of infection, and therefore is an entirely different ballgame compared with malignant pleural effusion.
Yeah, no, I think it's a really good point, Gary. It's something that I've got limited experience of this. Most of the centres that I've worked at haven't offered this with any sort of enthusiasm. We've been very reluctant to do so, and anecdotally, the experience and what the data would show actually is that many of these people have lots of issues. The consumables, so yes, larger fluid volumes. So in reduce of course, we were talking about 17 litres. That's a lot of bottles. So there's cost involved with that. And of course, just at a practical level, what we're seeing is drain migration, slipping of suture lines, infection. So a lot of additional issues that we perhaps don't see in that MPE cohort. The duration of survival, I think, is often very tricky. Many of the patients that I'm referred are very much on their last legs. They've had sequential large volume aspirates. They have postural presyncope. Their kidneys are failing. So their treating physicians just can't push those diuretics anymore. And so often the outcomes for that group are very poor. And so perhaps even, when we compare them to, for example, someone who's got mesothelioma, we're often finding that the outcomes in the malignancy group are markedly better. So that's the only caveat I'd say. But yes, lots of practical issues with that.
Yeah. So you touch on that. The reduced trial, the reduced RCT is very much cited. But as you mentioned, in the control group, they only have 1.3 times of fluorescentesis.
Yes.
It's not quite the usual population that we're talking about, refractory transudative pleural effusion. What's your take on that?
Yeah, it's very interesting. I mean, when we've been looking at this with the ERS guideline, even refractory, the definition we don't really have consensus on. Are they patients who have effusions despite what we would call optimal medical management, or is that a group that are still reaccumulating despite that first orocentesis? And yes, the volumes in the usual care arm in reduced there is actually quite small, but I think that once again perhaps comes down to just how multifactorial the mechanisms of breathlessness are in this group. And perhaps it's, these patients certainly feel better the moment you drain them. The question I wonder is, when you look at that over a prolonged period, whether, the improvement is just lost. Certainly when you do the procedure, they feel markedly better, but then perhaps they revert to breathlessness again faster than your other populations would.
And there's always been a suspicion that if it is a transudative thing, the chance of a re-expansion pulmonary edema when you drain a large volume is higher because of the lack of osmotic pressure, etc.
Yep.
What's your advice on that?
Yeah, really hard question. I mean, data on re-expansion is so limited, of course, because it's such a rare thing to have happen. We certainly, the patients where we've put IPCs in, we've generally limited the drainage volume. So we've said we're going to keep the catheter in, but effectively use it as a ambulatory large volume drainage strategy. So that might be no more than 3 drainages of a litre per week. And so thinking of it as 3 sequential large volume aspirates, and hopefully that reduces that risk of re-expansion. The case that I illustrated there, where someone had a drain inserted and 4 litres at a time drained, I don't think that should be the standard of care, knowing what we know.
Yeah. When it comes to hepatic hydrothorax, we often have this debate, argument, discussion in the hepatology ward. They always give people albumin because that's what they do for ascites.
Yes.
I won't bias your answer, but tell us what you do.
What I do, I tend not to give albumin. I think they might seem similar, but they're two very different spaces. And I don't think the albumin helps. But in saying that, we don't do it often. But no, we wouldn't give albumin in that setting.
Yeah, that's what I do as well. I told them that the fluid has already migrated from the abdomen to the pleural space, so the decrease in hydrostatic pressure shouldn't cause a sudden fluid shift. But it's often very difficult to change practice because in the hepatology ward, it will be a lot of people having ascites drain where they do need albumin.
Albumin. Yep.
Got a question here. Any thoughts or consensus on using CPAP before and after TELC to increase the intrathoracic pressures to increase the success rate? I think this is based on. I think I'm old enough to remember that is based on a study from South Carolina where Stephen Sands gives people CPAP after TELC in order for hepatic hydrothorax to keep the fluid away from the pleural space, and shows in that small series a good success. I don't know if you've ever tried that or.
I haven't tried that. I mean, whether you'd have to have fairly high CPAP driving pressures, I would have thought, to do that. But look, it's not something I've considered. It seems like the idea has been tried in other cohorts. So I honestly don't know. But on the face of it, to me, that there would be some issues with that.
So again, I'm old enough to have tried a few times, but I think when you try to do that for 24 hours, and for a few days, 24 hours round the clock for the patient afterward is extremely difficult, and most people don't tolerate that. And it may work, but I think we've tried it. In principle, it works because you can actually see that when the patient is on the CPAP, the drainage on the tube is significantly reduced. But just very few people can tolerate being on 24 hours for, and I start with about 5 centimeters, and it just doesn't work. We've got another question here to say that I have problems in convincing our cardiology colleagues in believing that the pleural effusion is cardiac. How accurate is N-terminal pro-BNP? Can I, be firm to say that this is a cardiac pleural effusion?
Yeah, no. Great question. So I'd take a step back from that and say even a blood pleural fluid, a blood BNP performs really well. So there's a recent systematic review looking at this, 4 trials, I think, looking at blood, and it gives you a sensitivity of about 90%, and a specificity of about 88% or thereabouts. And pleural fluid performs as well with a larger data set. But if you've got a BNP of greater than 1500 on serum, that is strongly suggestive. So I often do this myself. Even if there's someone who I know has left ventricular failure, I will often order a BNP to help convince a colleague.
Another question here. Most of these transudative effusions tend to be bilateral, and the person asking the question say that sometimes I find that if I drain one side, then the other side gets bigger. And also, I think anecdotally, all of us have seen cases where if you pleural these one side, that's taking it a bit more extreme, then the other side got worse. What's your point? What's your take on it?
So my take on it, so the fluid shifts occurring, that's something that we certainly speak about and have seen. The question about increasing fluid on the contralateral side, it's not something that I've necessarily, recognized, I must admit, in my own practice. The group that, just this is a slight aside, speaking of the contralateral side though, but what I think is really interesting is the effects on the contralateral diaphragm. And certainly when you've got bilateral effusions, I suspect that these patients are markedly more breathless because of the lack of compensation of the contralateral side. But whether doing a thoracentesis on one side certainly doing a pleurodesis on one side might cause fluid shift. Whether doing a thoracentesis on one side will necessarily lead to fluid developing on the other, I'm not aware of anything to support that. Not to say that it doesn't exist, of course.
Yeah. How about albumin infusion benefits in those with both hepatic hydrothorax and ascites?
Yeah, so I think an albumin infusion, if you're going to be intervening on the ascites, I think go for your life. I think to Gary's point, when we're intervening in the thorax, that fluid is well and truly left the abdomen, and so there may be groups doing it. Certainly wasn't practiced during my fellowship, but I'm not aware of any centres who are routinely giving albumin for hepatic hydrothorax.
And one important question often is if people are going for liver transplant or potentially on the list for liver transplant, does that alter what you would do for the hepatic hydrothorax?
Yeah, great questions, Gary. So a lot of these questions don't have good answers. This is something that we've discussed often, and there is a view that perhaps IPCs and the risk of IPC-associated infection make them less suitable for patients undergoing liver transplant. But in saying that, there are lots of North American centres and at least one British centre that are reporting really good results with IPCs in the lead up to transplant. So we just don't have the data to make firm statements, really. So there are expert centres using IPCs. There are others that will say no IPC because of that risk of infection.
Yeah, I think we tend to let it as the absolute last resort in the potential transplantable candidates. Sounds like you do the same. Yeah. You do touch on a little bit about those new fancy cardiac drugs. I did go to a grand round and I noticed all these new names that I never heard of before. What do you think of that? Would you have tried them and push harder for those medical therapy before you go and drain?
Absolutely. So my first effort with these patients is to try, I mean, the inpatient teams are obviously working very hard. Often you'll get the odd GP referral where getting them to a cardiologist who can get them onto what is the best evidence-based cardiac treatment changes things. And anecdotally, I have heard that, Reduce 2, which was going to look at IPCs in heart failure, has found that population perhaps has reduced somewhat because of the efficacy of the new cardiac drugs. So certainly I would say that if you've got patients who aren't optimally treated or managed by a subspecialist in that area, I would certainly link them in with that. And what I will often do is just do a large volume aspirate as a temporizing procedure while that happens. But generally, we have to be dragged kicking and screaming to put IPCs into many of these patients.
And another question is, if you face with a patient with a large effusion, would you consider at least offloading some fluid so that it starts from a lower baseline before you start diuretics? Otherwise, it might take a long time before it drains out the whole hemithorax.
That's a great point, Sanjeevan. So that's exactly what we would do. So if we've got someone who is breathless, we can see they're breathless. We would take off 1.5 litres as essentially as a day procedure or as a rapid procedure, say on the cardiology ward, and then that will hopefully. The data is very good in terms of alleviating breathlessness. So it's, depending on whose data you believe, somewhere between 73 and 86%. And then that gives the other teams time to perhaps get control of the situation.
And the next question was about peritoneal dialysis related Peru effusion and whether you ever used injecting a dye like methylene blue into the ascites and then confirming that it's a peritoneal dialysis.
I have not done that. I'd be keen for your thoughts, Gary, actually, or senior colleagues.
I mean, first of all, that is actually quite uncommon. And secondly, when it happens, it's usually very, very obvious that, you put in the dialysis things and then the patient develop a large effusion. But I think if there's any doubt, then injecting a dye is a reasonable thing. But I think nowadays we might even think of something that is radio opaque, so you don't then have to tap the effusions to look for it. But it is quite a significant issue because, at least in our center, if you have an episode of that, then they are taken off peritoneal dialysis, so they go straight to hemodialysis. So it's quite a significant impact on the patient's renal management. So if there's any doubt, I think it is good to clarify, but in most cases it's fairly obvious. And I think you can do the biochemical analysis of the fluid, and it would be more the peritoneal dialysate rather than a transudative renal overload effusions. So does anyone has a last minute question? Otherwise, we have had a great discussion and a great talk, and I'd like to thank Dr. George again for this. And just to advertise, next month we're going to have Dr. Celia Green, who is one of our expert pleural cytologists, to talk about teaching us how to read cytology or understand that. And I think that's a very, very important topic. So first Wednesday of each month at 4 p.m. Sydney time. And look forward to seeing you next month. And the today's, as well as the previous TAPS series, are all on YouTube. Just put in the Australasian Pleural seminars and you can watch them again. Thank you very much, everyone. Thank you.
Thank you.